delighted to welcome our first speaker, Dr. Reem Suwaidi from Rashid Hospital, and her presentation will be on real-world experience in Ocrevus patient early switchers. Dr. Reem, the floor is virtually yours. Please, your presentation.
Thank you, Dr. Jihad, for this kind introduction. Let me share my screen with you. Good afternoon, everyone. I'm Dr. Reem Suwaidi, neurologist at Rashid Hospital. We will be presenting with you some real-world evidence on ocrelizumab, as well as a case presentation. Starting with Opera 1 and Opera 2 open-label extension study, we'll go through a few data. Of course, starting with the design of the study, it was a double-blinded study. One arm of patient receiving interferon and the other arm receiving ocrelizumab. It was for 2 years, and then there was a 4 weeks of a screening period to go through the open label extension study, where both groups were switched to ocrelizumab, and they were maintained follow-up almost more than 4 years. So we have collectively more than 6 years data. We can see from this first graph, ocrelizumab effect on the annualized relapse rate. We can see from the first 2 years data, there was a rapid reduction in the annualized relapse rate in the ocrelizumab group comparing to the interferon group. That was maintained even through the switching and the open label study for both the group, the ocrelizumab and the switcher from interferon to ocrelizumab, going into the almost 6 years of data, showing approximately patients have less than 1 relapse in 20 years. That's what we all want in our patient. And the benefit of initiating ocrelizumab on the clinical disability progression at 24 weeks, that was maintained even through the open label extension study. We can see the benefit on the ADSS disability progression that was at 24 weeks. It continued and maintained throughout the 6 years data. What about the MRI activity? T1 lesion, GAD enhancing. Through the double-blinded study, we can see significantly reduction in the T1 GAD enhancing lesion in the ocrelizumab group comparing to the interferon group. Not only that, as well as the enlarged or a new T2 lesion that both demonstrated in the double-blinded period. What about when we switched patient both in ocrelizumab continued and switch from the interferon? We can see almost complete suppression of both T1 GAD enhancing lesion or the enlarged or a new T2 lesion. Here we will, in this graph, we will look at the point where patients were switched to ocrelizumab or continued on ocrelizumab. So we can see the huge difference in the mean EDSS score difference from the baseline. That patients who were switched have much higher EDSS comparing to the patients who are initiated on ocrelizumab and continued on it. Why they assess the 48 weeks confirmed disability progression and compared to the previously 12 and 24 weeks assessment? Because at that point, to demonstrate excuse me, the efficacy, that was, so why did we choose the 48-week confirmed disability progression point? It will demonstrate to us that the initial disability was maintained, and even at the 48 weeks, it was wider at that point. We'll see that the reduced risk at a 48-week and confirmed disability progression, we can see that the ocrelizumab group it's obvious on the graph the huge difference between the interferon group and the ocrelizumab group. Ocrelizumab gave us a 57% risk reduction in the EDSS disability progression at 48 weeks. And that was also maintained throughout the open label extension study. We can see even with a patient who wore switch, they had some reduction that was not as comparison as the patient who continued on ocrelizumab from the beginning. What about confirmed disability improvement, which means a reduction of 1 point in the EDSS score for a patient who have EDSS less than 5.5? We can see at 24 weeks, there was a 31% reduction in the ocrelizumab group comparing to the patient who are on interferon. Not only on relapse rate, not only in the disease progression, even in the whole brain volume loss, there is a statistically significant reduction in a change in the baseline and the whole brain volume in the patient receiving ocrelizumab comparing to the interferon. That was also maintained throughout the open label study. So more than 6 years data showed lesser brain volume loss in the ocrelizumab group, and that was maintained throughout the open label extension study. So how these data help us and understanding the safety and efficacy of ocrelizumab? Through the double-blinded study, the significant reduction in the relapse, annualized relapse rates, as we mentioned, there is a significant reduction in the EDSS compared disability progression, as well as reducing the brain lesion, either T1, GAD enhancing, or a new T2 lesion through the ocrelizumab studied patient, as well as increase the number who reached NIDA. Through the open label study, what did we also get? That the initial reduction in annualized relapse rate, it was maintained through the over than 6 years period of data, as well as early initiating of ocrelizumab showed us a lower brain tissue loss over time. That was also maintained through the whole period of study. Switcher from interferon to ocrelizumab show abrupt and almost complete an MRI disease activity. Also, of course, the disability benefit and confirmed disability improvement that was mainly with the ocrelizumab patient. Trying to implement that on a real world patient, we'll start with a case from our hospital. A 37 years old Emirati female who her history started in 2006. She presented with imbalance, weakness, and bladder symptoms. Her initial investigation, MRI, showed multiple brain lesions, cervical lesion that was consistent with multiple sclerosis, evoke potential, and CSF study were positive. Her vasculitic workup was negative. That was her MRI, showed multiple T2 lesion involving bilateral hemisphere, mainly white matter, and as well as cervical lesion. She was started on interferon at that time, and unfortunately, she developed a significant elevation in liver enzyme, so interferon was discontinued. She was following outside of the country, unfortunately, and she was started in off-label intravenous immunoglobulin as a maintenance therapy. Unfortunately, she had many relapses at that time, requiring multiple episodes of intravenous methylprednisolone. A follow-up from 2008, where she presented to our hospital. She was just delivered and she was breastfeeding, so no DMT was started at that time. We discussed with her option, and natazolumab was one of the options that she opted for. Till the approval went in. She started her first dose in April 2010, and she was stable clinically up until November 2012, where her GC virus came positive. So natalizumab were stopped. Decision was there to change her to fingolimod. Unfortunately, from 2013 till 2016, while on fingolimod, she deteriorated. She had multiple relapses. She had one of her significant relapse were the one she was admitted to the hospital with to receive a plasma exchange. She was unable to walk, and she had 5-session plasma exchange physical therapy. Her ADSS was changed on discharge to 3.5. Subsequently, she continued to progress. Her ADSS increased from 3.5 to 5.5, where she entered the secondary progressive phase. The question here and the point is, if we had all these available therapy at that time when she converted to JC virus positive, and we know a young female with multiple relapses, she was stable on medication, but now we have to change. What could be a better option for her at that time? We'll have a polling so all the participants can vote. So I know it is 2013, but imagine that we had all the luxury of all these options. What would you have put the patient on? 2 more seconds, no restriction, look at her profile, and keep in mind that we know that she worsened, her ADSS went up. What could we have done differently to prevent that? You all are welcome to vote. Few more seconds. Okay. So 33% went to dimethyl fumarate, and we have equal of alemtuzumab and ocrelizumab, and some two chose cladribine, fingolimod. Okay, some wanted to go through the same course that we already had. Presentation. Unfortunately, up to 2018, many of these therapies were not available. And only in April 2018, patient was switched to ocrelizumab. At that time, her ADSS was almost 5.5. And up till 2020, when follow-up, her ADSS remained stable at 6. And I could go through the point that now the progression phase and all this, but what we actually wanted from this case, I could have shared the case that a patient miraculously improved, start walking. But what I wanted to emphasize on, to choose the appropriate treatment on the appropriate time. If we had all this available therapy at the same as this time, and a patient who came with us who had multiple relapses, we know that her MRI has multiple lesions, we can say moderate to heavy burden. Why not to go to the higher efficacy drugs where we have all the evidence that showed there is decrease in annualized relapse rate, decrease in a progression confirmed disability scale, decrease in a brain volume loss. We have multiple therapy that we can choose from. So encouraging to choose the appropriate treatment to the in the appropriate time. We can discuss more on the Q&A session. That is mainly my presentation, and thank you, everyone.
Thank you, Dr. Reem. Excellent presentation. I know you were very busy with patients this morning. You saw many patients, so your voice got exhausted. So it's time to rest now.
Thank you for understanding.
Yeah. So we will just remind the audience, you have Q&A icon down. So we'll take care of your questions. If you have any questions or comments, we'll be more than happy to address them. And now we move to our next speaker, my friend, Dr. Ali Muhammad Hassan. It's my pleasure to introduce him. He's a consultant neurologist at Nov16 Hospital. He's a single speaker, and his expert is not only multiple sclerosis, migraine, MS, stroke, Botox injection, and others. And I'm delighted to welcome her and and his presentation will be on women dominate now, no? The role of Ocrevus in naive and switch patients. So Dr. Ali, the floor is yours, please.
Thank you, Dr. Jihad, for this nice introduction as usual. So just allow me to. So good evening, good afternoon, everyone. So my task was be a little bit different from Dr. Reem, which I enjoyed her presentation. So I will just present a cases that high efficacy DMT in multiple sclerosis can it affects the outcome of our patients, which is a question we have to make sure we have its answer clear in our mind when we choose medication. So my first case, it's a young story. As a male patient, 32 years old, who started with in 2009, started to have a double vision, dizziness, balance problem, and on and off paresthesia. And he was roaming around the hospital. And 2012, he has started developing weakness. And finally, in October 2012, he diagnosed with relapsing TransformingMS. And in 2013, he has a recurrent yard limb weakness in March, May, and June. And he was started on beta-ferron on May 2013, which he has a relapse after it in June 2013. And first time seen in our hospital was in September 2013 when his EDS score was 1. So this patient is carry multiple bad prognostic factors, multiple relapses, and May 6, and he was a little bit late in starting or initiating his DMD. So this is his MRI, first MRI we had in our hospital. As you can see, he has multiple periventricular lesions, and his MRI cervical spine was a horrible one. As you can see, I hope you can see this. He has a multiple lesions in cervical spine, and also in the dorsal spine he has multiple lesions, which one of them was in the corners, and this spinal was presenting symptoms for him when he has this monoplegia in his lateral limb. So in November 2013, natalizumab was offered to him when he came to us with beta-ferron by our colleagues. So the patient preferred at this time to be on oral therapy. So fingolimod was started in January 2014 after 1 to 2 months of discussing with the patient's review and cons for oral versus injectable at that time. He had fatigue, bad mood, so duoxetine was added for him at this time. And after 3 months in April 2014, he still have increasing spinal cord lesions, additional spinal cord lesion, and one in the craniocervical junction, new lesion, which was not there before. And he has some contrast enhancing lesion. It's a minimal, but it is there. So at this time, he was again discussed with them the view and cons of natalizumab, and he finally agreed to start it, and it was started 6 weeks after washout of fingolimod. At this time, his ADS score was reduced to 2.5. And we continued for almost 2 years of natalizumab monthly doses, and unfortunately, his GC5 status converted positive with a high index up to 3, which was fluctuating in the following years when following up. So he had MRI follow up while he was on natalizumab. He has 4 MRI, and all of them was stable, nothing. And actually, he's improving on his clinical status. His ADS score dropped from 2.5 to 1 on natalizumab 22 doses. So in April 2016, when we have this high titer of GC5 antibody, he was scared to continue on natalizumab, and he shifted to DMF with some gastric side effects and flushing. And he continued with it for about 8 to 9 months until February 2017, when we take a decision of changing the medication because the patient cannot anymore tolerate the medication. And at this time, radiological activity was evident in the MRI, and the patient himself is starting to have subjective imbalance and increasing psychiatric symptoms. And his ADS score was deteriorated again from 1 on natalizumab up to 2.5. This is his MRI on January 2017 while he was in DMF, and as we can see, we have many juxtacortical and cortical lesions now, which was not there in the first and second MRI, and who has contrast enhancing lesions, even multiple enhancing lesion with the MRI. Again, for up in DMF showing contrast enhancing, CAD enhancing lesions. So we started him in 2018 in January. Shortly after we had ocrelizumab in the country, we started him immediately on Ocrevus because patient was on natalizumab, fingolimod, DMF, interferon. So he was a highly active patient, radiologically and clinically. And we cannot continue on natalizumab, so we chose to shift him to Ocrevus. And till now, we received 6 doses. So what happened through this release? So after the first dose, in January 2018, I have some fatigue, increasing frequency of urine and anxiety. ADS score started to drop again to 2. And we added him amantadine for fatigue, but he cannot tolerate it. We shifted to modafinil, and he has a good response for his fatigue while on ocrelizumab. After 3 months of the first dose of ocrelizumab, the patient was almost asymptomatic, except for the fatigue by the end of the day. Sorry. So this is his MRI in October 2018, and there's no evidence of any contrast enhancing lesions, as we can see here in the T1 was enhancing lesions, and he saw some lesions, but it's all odd. There's no any added T2 lesions, and there's no any contrast enhancing lesion. And this patient, to the COVID, we have for him since March, two consultation done for him, March and July, and he came physically to us to the infusion center in August when he has the 6th dose of Ocrevus. And his current ADS score is 2. It was 2.5 before starting Ocrevus, because there was 1 on natalizumab, and then with other oral medication, it dropped to 2.5. So it's more or less stable or showing minimal improvement for the last 2 years in comparison to the 2 years he was in the oral medication. We have multiple relapses and clinical duration, even ADS was deteriorating from 1 to 2.5. This is his last MRI. We did it in July here, we can see some black holes of the old lesions, but none of them are enhancing. We don't have any T1 enhancing lesion. So do we have evidence for what we did for our patient? Yes, this is some evidence from this paper which was published in the American Neurology Association CCE 2020 conference. They compare the moderate versus high efficacy TMD after natalizumab discontinuation for the MS. The same exactly what we did in our patient, but in a large cohort study, they have about 565 patients with MS from 2 big centers in the US. And to discontinue natalizumab, most of these patients due to risk of BMA, which is due to positive GC5s, paroxysmal seizure was minimal or only 15%. Adverse effects was only in 17% of the patient. So shifting strategy was stratified in 2 arms. One for moderate TMD, which include TMF and fingolimod, which about 140 patients, and 130 patients, total 270 patients for oral medication, versus to a high efficacy medications, which was almost for ocrelizumab 160 patients, alemtuzumab 7, rituximab 17 patients. And they assess the patient using probability score weighting. And what they found, although there was no any significant statistical difference in the relapsing rate between both, however, the participant who switched to a moderate TMD has more percentage of new T2 lesion, radiological activities, including T2 lesion and CAD enhancing lesions, and 20% was deteriorating on 25 foot walking test and 9 Holbeck test, which means you have a clinical duration can be objectively found in them and radiologically. So there was no definite relapsing activity was found. The percentage of the patient with absence of disease activity was lower in the group treated with moderate TMD versus high efficacy TMD. So the natalizumab switcher to a moderate TMD, which is oral medication, had a lower cumulative probability of no disease activity by 2 years and were at a greater risk of disability accumulation with the time. This was the conclusion of the study. So this is typically about or typically describe what we did in our patient exactly. So this one was a shifting patient from medication, other medication to ocrelizumab. Now we go through a short presentation for a naive patient. So this patient is a MA patient. He's 27 years old with no previous chronic medical history. He was working at with heavy machines. So I saw this patient basically in 2016. He has a word presentation at this time was only isolated that 6 nerve palsy. And the MRI we did at this time doesn't show any evidence of MS, very tiny, what non-specific lesions. And we follow him with another MRI with contrast, nothing is there. Patient refused lumbar puncture at this time, and we followed him for 1 year, and since the patient didn't come again for follow-up to the hospital, as he was totally asymptomatic and he's improved symptom. And this was a typical presentation. If you have isolated 6 nerve palsy, it's a little bit weird to have it in MS. So in July 2019, after about 5 years, the patient have a transient paraparesis. And he came to us with a paresthesia, actually not a paraparesis. This paraparesis was fluctuating, and the patient didn't take care. But once they have this neuropathic pain and the paresthesia, he came to us in the hospital. And we repeated his brain MRI, which showed typical enhancing lesion, cervical spine, and especially in C4, and his first criteria of MS. So he has evidence of dissemination in time. So it was tobiopia in 2015, not typical, but it was dissemination in time for us. And dissemination in space is evidence in BX and circular quarter, B, ventricular, and the posterior fossa. So he first criteria of MS for us. And to discuss with the patient and his family at this time, multiple medications options, and because he has a spinal cord lesion, we classified him as a heavy yacht or aggressive disease, because spinal cord or infrasternal lesions were always scared and classified the patient as an active or highly active disease activity in this type of patient. So this is his MRI in 2014, and can we see in his VA image and T2, this hardly seeing 1 or 2 lesions, which is not typical for MS. It's not ventricular, not circular cortical. So it's a deep white matter with non-enhancing lesion at all. And that's what all we found in 2014. Unfortunately, at this time, we didn't do MRI spine because the patient was totally asymptomatic from the spine perspective. It's only have some tibiopia and typically isolated 6 nerve palsy at this time. Since his MRI in 2020, here we can see more lesions. It's not typically fulfilling all the criteria, but some of them was seeing like a circular cortical lesion, ventricular, but his spinal MRI was showing multiple lesions, and some of them was contrast enhancing lesion. That's why we fulfill the criteria of MS in this patient. So the patient started on Ocrevus in 2019 based on high active lesion and high active disease activity and the patient preference at this time. And we have 3 doses for him till now. And last time we saw him was in 2020. It was 2 months or 3 months back. We saw the patient physically, and the patient has no symptom, and his ATS score is 0. So do I have an evidence about this? Yes, there's some evidence, and this is available just published in 2020 also in Science about timing of high efficacy therapy for multiple sclerosis. What they did, they collected a patient with relapsing rheumatic MS, and at least this patient had a 6-year follow-up since the disease onset. And they classified the patient into 2 groups. Those groups who started high efficacy medication in the phase 2 years, this medication including rituximab, ocrelizumab, alemtuzumab, natalizumab, and mitoxantrone, or is this patient who started yet on high efficacy medications after 4 to 6 years. And they matched the patient on the basis of, say, baseline clinical and demographic data. They cross-matched the patient. And they look for the outcome, main primary outcome was satisfiability, measured by ADS score at 6 and at 10 years after the disease onset, assessed with a renal mixed effect model. And what they found, how they interpret the result. So the high efficacy therapy commenced within 2 years of disease onset, like our patients, is associated with a less disability after 6 to 10 years. In a long term, the patient will have less ability to have more disability or cumulative disease disability than who started the high efficacy medication later on in the course of the disease. And this finding can inform the decision maker regarding the optimal sequence and timing of multiple sclerosis therapy to choose which medication to start with. So by this, I end my talk. I hope it was a short, aimed talk.
Thank you, Dr. Ali. Excellent presentation. We are waiting for questions now. I don't see any question in the Q&A. Please, listeners, type your questions in the Q&A and we'll take care of them. I would like to share my experience with the speakers that Ocrevus is a really effective treatment and it is safe, has established efficacy. It's very convenient to patients, especially those who don't want to come to the hospital frequently, so they come every 6 months. And I have many of these patients who travel frequently, so they come every 6 months for infusion and they do their business. I have personal experience. Many patients, their confirmed disability improved really. Patients who are with walker, they stopped using it. And I have some patients in wheelchair, they started walking without wheelchair, without any support. And this is the only drug I know that it may reverse disability. And it's very safe. We don't have any issues with safety. My question to both speakers, we have many of the patients switching from natalizumab because of GC virus positivity, seropositive conversion. So do you think there's any precautions, because there were some worries about GC virus PML to switch to Ocrevus? Any worries, any reported cases of PML or?
Actually, yes, there's some reported cases post natalizumab with Ocrevus about PMA. Some of them are explained by a carry-on PMA from the natalizumab itself, and some of them not. But it is not too much. And for my knowledge, I am not sure if we have any of these cases in the Middle East now. Alhamdulillah, I am not aware of any of these cases in the Middle East now and in UAE. We don't have any touch wood, any PMA confirmed case now. But there was some reports about carry-on and some few cases of PMA after ocrelizumab. But I think the assurance point that we have to follow what we have to do, which is MRI and clinical follow-up for the patient. We stay after shifting to Ocrevus. We have to follow up this patient by MRI maximum really for 2 to 3 years at least post Ocrevus, and then if it's stable, it depends on the case itself. If it's totally asymptomatic, we can widen it a little bit more, but still need to keep eye on this issue.
Thank you. I'm not aware there's any reported PML with Ocrevus so far. There is one question here. Ocrelizumab for how much duration? For how long duration? Dr. Reem? 1 year, 2 years, indefinitely?
If she means it's a, as we know, it's a 6-monthly infusion. That will continue. We can see the patient, they are longer than 6 years on ocrelizumab.
Yeah, on the open label extension study,
yes.
it's more than 6-7 years now. You are absolutely right, taking Ocrevus. So it would say this is long-term treatment. We cannot say 100 years or 5 years. Usually when the patient gets older, the disease activity will subside, and then you have to decide case by case for how long to give it. We have one question here. I'm interested to know about the role of interferons in the treatment of MS, please. This is a big topic and beyond the scope of this presentation, but interferons are first line. I take the privilege to answer this question. allow me, the speakers. So this is one of the safe drugs. It's long-standing, more than 20 years. We use it frequently during the COVID because it's safe. But efficacy is lower than the higher efficacy drugs, which mainly Ocrevus, alemtuzumab, natalizumab, and cladribine. So that's the first line, the efficacy and on annual relapse rate is something like 30–35%. The next question, just seconds to read it. How long do side effects last after Ocrevus infusion? Dr. Ali?
So it depends on the severity of side effects. So most of these patients have mild side effects. 20% of the patients have infusion-related reactions, and it's mild and it's controllable with the B medications. But rarely we have some patient in our hospital now. We have more than 150 infusion at least. Ocrevus, we didn't encounter except one case was mild. In the same day, the patient went home after some prednisone and antihistaminic without any young standing or needing admission even in the hospital. So most of these patients are treatable in the same day. They can go home in almost of the cases.
Yeah, usually before the infusion, as you said, we give pre-medication with steroid and antihistaminics. So far, we treated in our center more than 50–60 patients the last 3 years. We never face any problem. If you get allergy or some rashes, you reduce the titration, reduce the infusion rate, and then go ahead. We never require to observe any patient. It's relatively safe, contrary to alemtuzumab, which we see more side effects in the infusion reaction. The other question, does Ocrevus weaken the immune system? Yes, any volunteer? Does Ocrevus weaken the immune system? Of course, it causes CD20 depletion, so the immune system will be weak. That's why how it works. And in fact, before the infusion, every 6 months, we check CD20 to see if the infusion is working or not. There was some issue about the COVID pandemic and Ocrevus, but I think it was not related to the Ocrevus. The potential mentioning in literature was related to the age of the patient, because the MS population in the West is older than our population. Majority of our patients, they are 30–35, while in other countries in the West, the average is 60. So if any side effect happened, was related to age and comorbidities, not to the drug itself. Do you agree, Dr. Ali?
Yes, I agree to that. It's not awakened because even the infection rate in the studies was not too much, and it is some fire infection, and even we have our patient, none of them have infection. It's to be more cautious, especially about the pandemic, but this is for most of the medication for MS, because MS is an autoimmune disease, so any medication is working in the immune system. This is by default.
Yeah, I used to say at the beginning of pandemic, the whole world was panic about DMDs, and they didn't know what to do. So all the centers, we came to know from literature, many experts, that they delayed the initiation of many DMDs, including ocrelizumab, alemtuzumab, even natalizumab. But now we thought at the beginning the pandemic will stay 1 to 3 months, so we're back to normal. So we delayed the initiation, but we know that we are going to live with the pandemic for a longer period till the vaccination is available, and till the virus is maybe milder, not very aggressive. So we realize that we are going to live with it. So we are back to normal now. We are regular in scheduling ocrelizumab infusion every 6 months without any fear. We never face any problem. We have COVID-MS registry in the part of the GCC, and we reported 2 patients took Ocrevus. We have 16 patients took DMDs, including cladribine, alemtuzumab, interferons, and 2 were Ocrevus. They did very well, and they did not require hospitalization only. The only one who was hospitalized for 2 weeks was taking natalizumab, and 3 days after the infusion, they got COVID. admitted and discharged without any problems. We have GCC COVID-MS registry initiated by the Minactrims and by the MS base. So all of you, if you have any patient, DMD, COVID-MS, you can report it through the MS base. There is a form to be filled and you can send it to them. There is a question here, is Ocrevus approved in UAE or used off-label? Of course, it's not off-label. Rituximab is off-label for MS. It's not yet approved universally, but Ocrevus has been approved by FDA and by EMA. And in UAE is approved, I think, 2017, 18, and
17,
we were the first, 17, 16.
17.
17, yeah. We were the first country actually in the Emirate to use it in the Gulf and in the Middle East. And that's why we have more than 60, 70 patients using it in Rashid. And I think similar number in the whole Emirate. So it is labeled indication. My question to both speakers, I'm confused about pregnancy and Ocrevus. And myself and Dr. Reem were checking this.
So if Dr. gets confused, if Dr. gets confused, no one in Zambia will know.
No, really, we checked together with Dr. Reem. I know. So tell us, Dr. Ali.
So I was very interested in this matter because I have 3 patients at least in such right being born who want to get pregnancy, and there was failing many medication, and we kept on Ocrevus. One of them is BBMS even. So I discussed many times with international speaker and many guests, especially in Germany and France. They have 2 excellent pregnancy history for TMD in Europe. And I don't remember the name of these 2 female physicians, MS specialists, actually, but I know the faces, but I don't remember. I sat with them many times. So in the Zayebu, in US, it should be at least 6 months post-infusion. In Europe, it stays Zayebu 6 to 12 months from the last infusion to allow the pregnancy. However, this is it's changing, but not yet approved, which means they compare the Ocrevus, which is ocrelizumab, to rituximab because it's more or less the same component, but with some difference in the final component. So for rituximab, they have more than 400. Yes, please. So they have more than 420.
I mean, to be on the safe side, you are absolutely right what we said. There is differences between FDA and EMA. One is 12 months, one is 6 months, the washout period before pregnancy. To be on the safe side, because we don't have here Ocrevus pregnancy registry, so we recommend patients to no pregnancy for 12 months. However, I have 2 patients who got pregnant shortly after the Ocrevus, and they delivered healthy babies without any problems. And I think there is international ocrelizumab pregnancy registry. Till now, did not demonstrate any serious teratogenicity. But however, we don't recommend pregnancy. It's contraindicated during pregnancy. So there's a question here. I'm sorry, Wallah, but I'm not interested to know. I don't know who's this. Okay, many thanks. Any studies regarding side effect of ocrelizumab?
Yes, we have to start OBA1 and OBA2. We have a safety arm for it, and the safety arm was talking about this malignancy but it's not. When it's compared internationally to the malignancy rate, it was comparable. So there's no actual increase in risk of malignancy. But the other than to take care of the patient, to take the precaution normally should be taken by the human population of checking, especially if mammogram with any family history of breast cancer. But there's no definite increase in risk of malignancy or infection with some viral infection, but no severe infection found with ocrelizumab on the young time.
Yeah, okay, thank you. What are the chances of PML? This question, we answered it. Till now, there is no reported cases of PML, but if it happens, it will be most likely carry on treatment from previous natalizumab treatment and GC virus positivity. The next question, do insurance cover Ocrevus? We, myself and Dream, are governmental hospitals, so don't deal with Ocrevus with insurance. I think, Dr. Ali, you have experience with insurance. I think it's covered.
It's covered.
Do you have any comments on this?
No, it's covered. Sometimes some resistance, but finally it's covered for all. Most of yoga patient are covered, but for other Taman insurance, we have some resistance for it. It's not very
There's
covered.
another interesting question: how this medicine affect the comorbidities like bronchial asthma, cardiac problem, etc., etc. Basically, personally, I avoid using it in elderly MS patients, and with communication verbally through webinars with other international MS experts, they agree on this, but they said that most of their patients are above the age of 50 and they use it, so there's no real contraindication in this in comorbidities. Keeping in mind that most of our patients in the Gulf region, the Emirates, are very young, and their disease activity is usually at the peak between 20, 30, 40. So the ocrelizumab works nicely in highly active disease, and it works nicely in progressive. My best patient is active patient, active disease activity with progression. It works in supreme way, better than any other DMD. So this is my patient's profile, but again, we can use it in highly active naive patients. And from my experience with progressive patient, progression really was reversed. We feel it, I mean, when in our hospital, EDSS improved. What are the safety concern with finger mode to ocrelizumab switch in MS? Safety if you switch from fingolimod to ocrelizumab.
So I think he means the lymphopenia. So we have a washout period, and we shouldn't wait for recovery of the lymphopenia in patients with fingolimod to shift to Ocrevus. Second issue would be the carry on BMA cases, because fingolimod have some of the cases reported BMA. So it's a risk of carry over of risk of BMA to ocrelizumab. But other than that, I don't have information.
Yeah, absolutely right. Usually before starting ocrelizumab, we do screening tests. So we have to do full blood count, CD19 and 20, the anti-lymphocytes, T-spot and hepatitis profile, zoster profile. And if there is lymphopenia, we have to wait before starting ocrelizumab, what you mentioned, till it's normalized. The washout period between fingo and ocrelizumab, if it's normal lymphocyte, it's 1 month. If it's abnormal, we wait up to 3, 6 months, 4 months till lymphopenia normalize. So usually minimum should be 1 month. You don't switch directly, stop fingo today after 1 month. If lymphocytic count is normal, if it's not normal, we wait till it becomes normal. And screening test is very important. We have some patients, they got T-spot positive, which may indicate latent TB. So what we do usually, any comments, if you have T-spot positive, while screening for ocrelizumab?
I think this patient by IDs be referred to recover them with NTB for 6 months as a latent TB, or if you have T-spot or you have quantiferon positive, they usually prefer to start him on NTB for 6 months, and if you can wait for 6 months for Ocrevus, it's better. If it's mandatory, it should be covered with NTB with Ocrevus.
Usually we give one drug prophylaxis, isoniazid usually. Some people give Refina, which combination, as you mentioned, for about 6 weeks, and then you can start. We have one patient actually, he had suspected brain lesion. They are not typical of MS, and CSF culture was positive for TB. And then we didn't know what to do because oligocoronal bands was positive, and he was on interferons, but he's highly active disease. So we gave him anti-TB treatment till the T-spot became negative and CSF culture negative. And we started him on ocrelizumab, and now he's 3 years and ocrelizumab, and he's doing great. No disease activity, lesions shrink, and he's back to normal. EDSS is 1 almost. One question, Ocrevus has known to be drastically reducing IgG levels. Do you investigate IgG level frequently?
Maybe what
No,
she means
to
is
my
the B
knowledge.
cell. Yeah.
We want ocrelizumab to reduce IgG. That's why how it works. It reduces immunity because MS is disease activity. So you want to reduce the immunity. I'm not aware if it reduces the IgG clinically significant or not. Again, there's question about PML. Is there any case of PML among Ocrevus treated patients? My answer is no. I'm not aware of this. Does the drug have any broader implication for treating other autoimmune disease? Interesting question. Any comments? Do we use ocrelizumab for other autoimmune disease?
Not
I think rituximab. Yes, rituximab can be used cover both. Some we have one patient with SAE was confirmed MS. So rituximab we used to cover both in this case, but ocrelizumab I'm not aware he's approved for other diseases.
Yeah, rituximab can be used in myasthenia, NMO, CIDP, and off-label. They use it in other countries for multiple sclerosis, but we don't use it here. I'm not aware ocrelizumab, as you mentioned, Dr. Ali, is used in other indications. We have to search or do trials on other disease. The other question here, clinical scenario, it is a case. I'm not sure we'll have time to. 46-year-old lady diagnosed 2019 with intermittent paresthesia, bowel sensation issues, started on beta interferon. So she's MS, improves well, but relapses with bowel issues, constipation. What is the next step? MRI showed improvement lesions. So here the question is, interferon improves the relapses, but there's bowel issues. So what's your next step? Patient with MS, she got bowel issue. It's not clear what's the bowel issue. It's constipation, diarrhea, what is it? I'm not aware interferon may cause bowel issues. Any knowledge about this?
I'm not sure.
Maybe the site of injection in the abdomen caused some marks or something like this.
Not sure.
We'll check.
Maybe is it from the whatever she had before? Because we have to understand that MS is a disease. The relapses can have a residual deficit that the patient have to live with. Maybe this is about something residual. So she improved paresthesia, but still she have residual whatever power. I'm not sure what he mean, constipation or diarrhea, but it's very uncommon to have diarrhea or absolute only constipation as MS symptoms. I'm not aware of that.
Yeah, there's one thing here, maybe I can answer this in a different way. We did some study some years ago about MS and associated autoimmune disease.
Yes.
And we selected 100 patients here, and there was another center in Canada, 100 patients with MS and associated autoimmune disease. One of the common in both groups was irritable bowel syndrome. So if we assume that irritable bowel syndrome is an autoimmune disease associated with MS, we have to treat it separately. But in our group, in our cohort, there was diabetes, bronchial asthma, psoriasis, and thyroid disease. These were the common disease associated with multiple sclerosis. So this is autoimmune umbrella. You know, MS is one of them. Maybe other disease can be part of it. Should the patient avoid getting certain vaccines during the Ocrevus treatment? Interesting question. I leave it to the experts.
You as an expert.
Exactly.
Yeah, please.
Yeah. So I think if attenuated vaccination is contraindication with most of our MS medication, not only Ocrevus, because as you said, it's an autoimmune disease and it's an immune therapy considered as immune mutation or immune constitution. So it's depending on the type of the vaccination. If you've attenuated, yes, it's contraindication. But if it's not if attenuated, just a part, okay, or something, it can be given safely. But we have to avoid it, especially around the doses. If I select, I would select the patient to be given before 4 to 6 weeks before the next dose, which means after 4 to 5 months at least, to be in the safe side. But for if attenuated, we should wait until recovery of the beta cells, and we following CT19 and CT20, and if it's fully recovered, then we can give if attenuated, and the dose should be at least 6 weeks post vaccination.
Yeah, there's a question coming here. Do we give flu vaccine to MS? Flu vaccination, we recommend it usually for most of MS patients, but we have recently seen a MS patient. She'll come tomorrow to the clinic. She got flu vaccination. She's doing well for 10 years, but she got a relapse after vaccination, which is unusual actually. There's one issue here about, it's a common question asked frequently during the COVID pandemic. Do you recommend COVID vaccination or vaccination against COVID for MS patients? This question has been asked to many international experts. And we know there are some vaccines are available. They are excellent for normal population. But the international speakers from Canada, from America, from Germany, their answer was, we don't have enough information about COVID vaccination in MS group. So they recommend to wait till further data. Possibly in the near future, we will have solid data about vaccination subgroup. It might be great for patients with different comorbidity, diabetic, hypertensive, elderly, but with people with autoimmune disease, we don't have enough information. So I think the recommendation to wait till we get more information about this. What is the maximum dose for Ocrevus infusion?
It's one dose.
Yes, please.
It's a fixed dose. So phase dose will be 600 divided in 2 sessions, 300 after 2 weeks, 300, and then 6 months, it will be 600 fixed dose.
Yeah. As I said earlier, in the beginning of the pandemic, we delayed the infusions. And instead of 6 months, we did it 7 months, 8 months, and many centers in the world did this. But now we are back to normal or near normal. We have fixed 6 months, we give the infusions. There was interesting paper presented the American ACTRIMS in Washington in September about CD20. It was mainly rituximab. And the conclusion was smaller dose rituximab is as effective as big dose. And that's why they are giving, not for MS patient, for other autoimmune disease, myasthenia, CIDP, and other NMO, they give 500 milligrams every 6 months instead of 1,000 milligrams. And large study concluded 500 is effective like 1,000. But we don't recommend to do this because we are afraid efficacy and disease activity may increase.
So can I ask a question, Dr. Kat? Can I ask you?
Yeah, please.
So because this is another protocol to use 1,000 if you use 6 months, but 2 doses of 1,000, which 1,000, and after 2 weeks another 1,000, and then Q 6 months they have the same again. And this one,
this is what we do usually. Yeah, but this study said that if you are keeping a patient on maintenance dose,
yes,
1,000 or 2,000 every 6 months for different autoimmune disease, their conclusion was 500 milligrams every 6 months is as effective as 1,000 or 2,000. So if you are worried about CD20 I'm talking about rituximab, not ocrevus.
Yes.
So in this situation, we may reduce the dose. It is off-label, but it is a study presented in the ACTRIMS recently. So here, if question is there any problem with delay or missed doses of Ocrevus? I just mentioned this. It's better to be regular every 6 months, but if you are delayed for 1 or 2 or 3 weeks for any reason, there is no harm. Quite often patient will get, for example, on the day of infusion, he had flu, or he's not feeling well, or has gastroenteritis. So in this situation, we wait for 2-3 weeks and so on. Again, during the pandemic, we delayed infusions, but now we are back to normal. We are regular every 6 months without any problems. There is no risk of contracting infection in our infusion center is very safe. It's away from the COVID areas, and patients are happy with it, and the staff are very happy in infusing patients regularly. I think in Tawam you are doing the same, Dr. Ali. Dr. Ali, you are doing the same in Tawam?
Yes, yes. Now we're starting. Usually we postpone for 3 months from March to June, and now we're assuming all the patient to 6 months. We are not following the CT20 because we discussed many times with the expert at the beginning of use it, and there was no standard recommendation for following CT19 as indirect indication for CT20. So we are not using it actually. We're using the fixed timing doses to 6 months, but only 3 months from March to June 2020 was postponed all the patient until we had some more information, and now we assume it yearly to 6 months.
Yeah, thank you. Question here, do we start Ocrevus? This is for Dr. Reem. Specifically, she asked, after stopping interferons, do we start Ocrevus after stopping interferon or continue both parallel and then start Ocrevus and taper interferons? You are muted, yeah.
Yeah, I know. So no, patient will be on one disease modifying therapy. We don't choose multiple disease modifying therapy. So stopping interferon and then switching to ocrelizumab. We don't start parallel, and we don't take interferon.
We don't give both together, and usually there is no washout period. You can stop interferon today and next week start ocrelizumab. But there are washout periods with other medications like natalizumab, Gilena, we just spoke about it. Is there any local support group for MS in United Arab Emirates? Dr. Reem can answer this question. We are in a step of
working on, yes, we're in step of working on MS education and support group. So hopefully that will be starting soon. We're collecting the patient information data and under the umbrella of MS to have a large support group for MS patients. We have a website and educational session as well.
Yeah, sorry. Dr. Suhail is very active in this, and Dr. Reem is with great support. So hopefully soon we'll start some MS group supporting medication, education, campaigns. There will be virtual meeting with the patient. So hopefully in the coming few weeks, this will be coming to light. And I'm sure we are working hardly on it. The MS, and this is initiated by Dr. Suhail, presented the MS, and I'm sure it will be very successful. The question to both speakers, vitamin D is known to benefit MS cases. Can that be given along with ocrelizumab?
Yes, with any other medication.
Let me make some comment. Now we have some recently, means in the last 2 to 3 years, we identified many risk factors for disease activity, environmental risk factors. One of them, vitamin D deficiency. One is obesity. One is smoking, and non-unhealthy diet. So if you correct these things, you can, let's say, reduce or control disease activity. Definitely, one of them is vitamin D deficiency. For our information, vitamin D is under control of autoimmune system, and it helps to control the autoimmune system. And there was a large study done in Australia, more than 10,000 patients presented in one of the major meetings. They concluded disease activity is correlated to vitamin D deficiency. It does not cause MS, but it may provoke relapses and disease activity. And usually in the Gulf region, though it is very hot in summer, but we are not exposed to sun usually. So there will be vitamin D deficiency. And surprisingly, most of our patients, when we do vitamin D level, it is subtherapeutic, it's very low. So it is a routine practice all over the world to give vitamin D supplementation and to monitor it if it's 6 months, 1 year to optimize the level. So vitamin D is very important. It can be given with any DMD, with ocrevus, with interferon, with Gilena. It is given separately. And in addition, we recommend, of course, avoiding smoking, obesity, recommending healthy diet, avoiding stress, and so on.
Can I add a comment
Yes,
to
please.
Jihad? There was another study, and I don't remember which area, but it was a big study about deficiency of vitamin D is one of predisposing factor for MS if it is severely deficient before the age of 20. So if the child have severe deficient vitamin D up to the adolescent age 20, it was correlated with later development of MS in some cohorts.
Yeah, absolutely. Yeah. Thank you very much. Yeah. One of the other risk factors discovered also, we're looking for environmental factors, Epstein virus infection. The presentation, the American Academy last year or the year before, 99% of MS patients, they have antibodies again for Epstein virus. So viral infection is one of the important risk factors to develop multiple sclerosis.
It was 100%.
Sorry?
It was 100% in many other papers also.
Yeah, 99.9, so to say. Yeah, almost like, so here another question for Dr. Reem. What is preparation prior to starting Ocrevus?
Mainly, even before starting and choosing Ocrevus, we have to go through the screening, as you mentioned, Dr. Jihad, T-spots, liver function, CBC, HIV, and the hepatitis screening, as well as screening of malignancy, B and T lymphocytes. Prior the infusion, we have the pre-medication, which is the methylprednisolone, the antihistamine, and we can even give paracetamol, plus the monitoring, of course, of the vitals of the patient.
There's one question here. If the patient while screening, he is zoster antibody negative, so what we do?
So we vaccinate the patient and waiting 6
exactly.
weeks.
So in preparation, we vaccinate and we delay the infusion 6 weeks till the antibodies against zoster. And this same thing with hepatitis, same thing with herpes, and same thing with T-spot and TB, which you just mentioned, Dr. Ali. Now, one question from me, because we finished the questions here. First thing I want to share with you the switching from, you mentioned, Dr. Reem, about the OPERA and the open label extension, the switching from interferon to ocrelizumab at the start of OLE study was associated with a rapid and robust reduction in annual relapse rate and complete reduction in MRI disease activity, and was maintained for almost 3 years. And the second comment or query is, ocrelizumab data showed earlier initiation of treatment that it reduces disability. So do you have any preference here? Disease activity, progression, disability, progression? Which one you want to tackle more? Yeah.
It actually works on both. I know the trend is to, it will affect more on progression, that we should use it earlier to reduce confirmed disability progression, but it will also work on disease activity, both as in relapses and in MRI activity. So I think it works efficacy-wise on both relapses and progression. So we shouldn't withhold it when we are thinking of options and treating our patient.
Yeah. First of all, we don't have problems with infusion, really. We never called for infusion reaction. It's very convenient to patient every 6 months. Screening is very easy. Within 1 week, results will be ready. Safety issues are well established. Efficacy, we feel it in our experience. It's very effective. I can tell you, I didn't have single patient who had a relapse while taking Ocrevus. We didn't have really any patient having a relapse. Contrary to other medication, even with alemtuzumab, we have some patients got relapses. With natalizumab, some patients got relapses. Surprisingly, with the Ocrevus, when I review the cases, none of them had a relapse, which indicate very important efficacy on annual relapse rate, disease activity, brain volume, and EDSS.
Actually, we published our data in the last ACTIAMS. We'll be sending a poster for Ocrevus in our hospital. We presented all our patients for 2.5 years since we started in January 2018 to June 2020. And among all of our patients who tend to have a single relapses or disease activity, except one patient who have relapse within the first 2 weeks post infusion, which is not considered as counted against Ocrevus, but it is considered as failure of the previous medication. So, but we don't have any patient who has any disease activity or relapse on Ocrevus for 30 months, and for the side effects, we have only one patient among 20 patients in these 2.5 years who have mild infusion reaction only, and it was managed with IV methylprednisolone extra dose and antihistaminic, and the patient completes the infusion and went home in the same day.
Yeah, thank you very much. We have study in our Rashid Hospital Center. It's called consonant study. For patient, it is evaluation of safety and efficacy for patient taking ocrelizumab. It's ongoing for 2 years, should continue for 4 years. It is sponsored, supported by Roche, but specifically approved in our hospital. So we do evaluation for all parameters, blood test, MRI, EDSS, psychology, and everything. And it's really, the results are amazing. Patients are improving from all aspects. They are back to normal and working, and their mental function is good. Cognition is improved. So hopefully with completion of the study, it is multi-center international study, including Canada, centers in Canada, America, Germany, Europe. 600 patients are included in this study. It is very impressive, and the results till now are excellent. So do we have any, we don't have any more questions. There are some people putting questions in the chat. I cannot open it. So I think we, do you have any questions or comments to the audience, Dr. Ali, Dr. Reed? We make it reverse.
I hope they get benefit, yeah.
What?
I hope they get benefit and they understood the point that we were presenting, and hopefully it will affect their practice or change it for the better of the patient.
Yeah, I'm sure, because we reflected, we shared cases from your experience. It's practical more than theoretical. We mix both of things, and from very important centers from Tawam and Rashid Hospital. So with this, I'm waiting for last question if it comes in 1 minute. The question is price of Ocrevus in UAE. It came just like this. I'm not a businessman. I'm not supposed to tell, but I can tell you from the each vial is $7,000. So 2 vials, 600 milligrams is $14,000. I'm not doing business, but I know this, so I have to answer the question. But for your information, there is, in addition to the trial, Roche is having charity support to our patients in the Emirates. So for those having some financial issues, there is a form which can be filled by the health provider and can be sent to Roche, let's say, institution, and they study the financial status of these patients, and they can support them with either free treatment for some time or partial sponsorship, partial payment. So I'm happy with this. We have something like maybe 10 patients taking ocrelizumab free of charge, because it is one of the expensive drugs. So for governmental hospitals, it's given free, and insurance is covering it. So we don't have issues actually in providing treatment for our patients. I believe, Dr. Ali, you have the same.
Yes, we have the same, and we have in Abu Dhabi, we have on a card also included MS patient, and it's covered for ocrelizumab, but other Daman is not covered for it, but we have this charity that it can be covered. But most of our patients are yokai, so we don't have an issue in supplying them with the medication.
Yeah, we don't forget that ocrelizumab is the only drug approved for primary progressive MS. There's no other therapy officially labeled FDA EMA for primary progressive. And I think Roche is doing great support to the MS community, patients with MS community. They are doing trials, they are doing support financially to the patients, and they are doing educational support to the MS patients. So with this, I think we can conclude by thanking, number one, the speakers. It was excellent and interactive questions and answers. And by thanking the sponsors, Roche and Emens, collaboration with Emens, and the host, MCO. And before all, thanking the participants, the audience who interacted and listened well to us. And hopefully it was beneficial to them, as Dr. Reem said. And wish you a great day. There's, I don't know, there's evaluation form to be filled after this. If anything's come on the screen, please fill it. So thank you and have a nice day.
Thank you.
Thank you, Dr. Thanks.
Thank you, doctor.
Thank you.
Thank you. Goodbye. Take care. Bye.